during the presentation, you can put them in the chat box. We will take it up in the Q&A session at the end of the presentation. So ma'am, over to you.
Thank you. Thank you, Fetosense Zealmary Solutions, for giving me this opportunity. I'm very happy to join you all on a Sunday evening. And thank you all for joining on a Sunday evening. At the end of this, in the middle of the session, there will be a small break for about 5 minutes. And at the end of the sessions, those of you who want to ask any doubts, please, you can ask. Good evening, all of you. Thank you once again. Now, what are we planning to do today? We are going to discuss about the CTG machine, the tracing paper, what are the features to observe and how to interpret. I'm starting with the basics mainly because for youngsters, without knowing the basics, if we go just straight to interpretation, it may not be like you may not be able to grasp it so well. Okay. Two things that you should remember about CTG. Okay. It has a high sensitivity. It is very good at diagnosing fetuses which are good, which means if the CTG trace is normal, the possibility of the baby having hypoxia is very less. So most probably you will end up with a good baby. But supposing the CTG is abnormal, it does not mean that the baby will always be hypoxic. Okay, so this is where the interpretation and interpretation helps and waiting helps. So about the CTG machine, you have a monitor. In the new wireless machine, it's a tab actually. It is very convenient. It is easily mobile. And you have a Doppler probe where it picks up the fetal heart sound and a Toco probe which picks up the contractions of the uterus and a fetal movements probe. In this machine, the fetal movements probe is here. In the wireless machine, the fetal probe is here. And you have the paper roll. You need to know about the paper also. Then only again interpretation will be correct. Okay. The CTG recording paper has two parts. One fetal part marked F and a maternal part. Okay. This is for the new machine, new wireless machine, and this is the regular machines that we all use. See, let us go to the fetal part. In the fetal part, the heart rate is represented in the vertical axis, the time in the horizontal axis. Again, with different papers, it will be slightly different, the marks. The vertical axis in this machine, it will be in 30s. If you can enlarge and see, you see 30, 60, 90, 120, 150 like that. Whereas in this machine, it is in 20s. It is in 20s. So again, you have to be sure of what you are looking at. And the horizontal axis, it is represented, the time is represented here. Again, this machine, both the machines actually, you can set them in different speeds. Depending upon the speed at which you set the machine, it will be different. Generally, in India, we set at 1 centimeter per minute. See, you see this, 1 second, I'm just not getting my... Okay, you see this part of the graph is set at 1 centimeter per minute. Okay, when it is set at 1 centimeter per minute, this larger division will be actually 3 minutes. Okay, This same for the same patient, this was set at 3 centimeter per minute. In that case, the larger division will be 1 minute. Okay, here the smaller division. In the larger division, you have 3 bright. 1 second, I'll go back again. I'll show you this. Okay, so this is set at 1 centimeter per minute. So this larger division will show a trace of 3 minutes. It can be set at 2 centimeter per minute also. Okay, and it can be set at 3 centimeter per minute. Okay, generally in India we set at 1 centimeter per minute. When it is 1 centimeter per minute, this very small divisions you see, that will be 30 seconds. When it is set at 2 centimeter per minute, the smaller division will be 20 seconds. When it is set at 3 centimeter per minute, each small division will be 10 seconds. This is 10, 20, 30, 40, 50, 60. So that is 1 minute. So before interpretation, you should always look at the speed at which it is set. Okay, it will usually be printed in the machine. When you set it, when it prints, it will be written at what speed it is set. This again you can see in this CTG graph, you can see it is written 1, 2, 3. It says 1 minute, 2 minutes, 3 minutes like that. So each division is 1 minute and that is divided into 2. So that smaller division will be 30 seconds. So this is very important. And the fetal movements are marked by these arrows. When there is a spontaneous movement, this machine records it by itself. You can see a small black shadow here, black arrow here. That is a spontaneous movement, and this is a movement which is pressed by the patient. So this is 1 centimeter per minute. This is 2 centimeter and 3 centimeter. If you are used to interpreting the paper with 1 centimeter per minute, the 3 centimeter per minute will look as if it has less variability. So you should be aware how it looks with 1 centimeter, 2 centimeter and 3 centimeter. It is better to have a standard which is generally 1 centimeter per minute, and that is good enough for good interpretation. When you take the maternal part of it, the lower part of it, the contractions are traced in this. The contractions are recorded in Montevideo units. See, in the regular CTG paper with an external fetal monitoring, the frequency of the contractions can be assessed well. But the duration and the strength of the contractions cannot be assessed very well. The strength only will be represented by Montevideo units. So the horizontal axis again, you have to note, if you are setting it at 3 centimeter per minute, the entire division will be 1 minute. If you are setting at 1 centimeter per minute, this will be 1 minute. So you should be aware of that. And if in the olden papers, you can see there is one what is called as KPA. KPA means kilopascals. That actually is measured. It's a accurate measurement of the intrauterine pressure, which is done by intrauterine monitoring. It is not done by the external fetal monitors that we use. So that is only for research purposes that they use, and generally we don't do it in a routine clinical practice. So you can see in this 10 minutes you have 2 contractions. Okay. First and foremost, when you are doing a CTG, teach some basics to the woman, especially when she is in labor. Okay. The machine may show what is wrong, but unless somebody calls you and tells you, you may not be sitting with the patient continuously. So the woman is the one who is with the baby and the machine. So she has to know the basic alarm signals. Okay, so you should tell her that we are going to monitor the fetal heart rate by this machine. Okay, we may do an intermittent monitoring or a continuous monitoring. if you are going to do continuous monitoring for high risk patients, you have to inform the woman that we are going to put this continuously. If you want to have a break, if you want to go to the bathroom, or if you want to have a break, you should let us. So the patient has to be counseled. Then she has to be told if the heart rate is in this green part of the graph paper, it is within normal limits. If it goes above or below, or if it is erratic, please call us. We will be monitoring, but if there is especially a prolonged deceleration, if it is not noted within 5 to 10 minutes, the baby can be really hypoxic and there can be a problem. So she has to be taught the basics and then proceed. Then how do you position the patient? Ask her to empty the bladder. A supine position has to be avoided in pregnant women, all of us know. So it has to be a lateral recumbent or a semi-reclining position. Half sitting positions are recommended. When you put a continuous monitoring, okay, with the machine with these wires, it is a real disadvantage because it immobilizes a patient, whereas the labor will progress better if the woman is mobilized. So the new wireless machine is of great help. The patient can sit, move around, walk around, and still the baby heartbeat can be monitored. And before placing the Doppler, Dr. Kalaivan,
ஆயில் ஃபுல் கேன் வாங்கிட்டேன். நாளைக்கு போயிட்டு நான் ஹார்பிக் அந்த டீ பவுடரும் வாங்கிக்கிறேன். இது எனக்கு வாஷ்
organizer, please mute everybody else.
சொல்லு அது இருக்கு ஹார் அதெல்லாம் இருக்கு.
Organizer,
ஆயில் கேன் இல்லை, ஃபுல் கேன் நான் காசு கொடுத்து வாங்கணும். ஓப்பன் பண்ணல இருக்கு, இப்போத்துக்கு தேவையில்லை.
Ma'am, please unmute.
Yeah, unmute. Okay. So before placing the probe, locate where the heartbeat is. Is it on the right lateral side, left lateral side, or in the midline? So you locate the heartbeat. Where it is best heard, you place a Doppler probe. Then you feel the maternal pulse and make sure you are not recording the maternal pulse. Okay. One second. Ma, aprama koopudunga ma. Aprama koopudunga na I am class. Sorry, I will put it on mute itself. Okay, so this is very, very important. It is always better if you write the maternal pulse rate also in the recording so that we are sure we are not recording the maternal pulse rate. Write the name, date, time, and the gestational age of the patient. Again, in the new machine, unless you give all this information, the machine doesn't take up. So it is a good thing. All that is given in the recording paper. The Toco probe has to be placed on the fundus of the uterus. The Toco probe has to be tied with the correct tension. When you put the tape, if you put too much pressure, again, the Toco may show that it is like a hypersystole. If you put it loose, it may not show any recording. It may be difficult in an over-distended uterus in an obese woman, but as much as possible, give the correct amount of tension when you put the tape. And remember, the Toco probe always has to be placed in the fundus of the uterus. Fetal movements probe has to be given in her hands and ask her to press whenever she feels a movement. And the tracings are generally taken for 20 minutes. Why it is 20 minutes? Generally in 20 minutes, there will be at least one movement and there will be one acceleration at least. And 20 minutes is a reasonable time for the woman to lie down and have a trace. So these terminologies, what do they mean? CTG is cardiotocograph. This you understand. Electronic fetal monitoring. NST. These are all the same tracings. In different situations, we may call it differently. Non-stress test. When a pregnant woman is coming and she is not in labor, when you want to do a CTG tracing, you call it NST because there is no stress as such, and we are trying to see how the heartbeat rate and the responses. CST is contraction stress test. Like you put a syntocin on, see how the response is. That is contraction stress test. It can be syntocin or misoprostol, whatever. Induce labor and then put the machine. Intermittent monitoring, it can vary once in half an hour or 15 minutes or 5 minutes depending upon the stage of the labor. If it is high risk pregnancy, you will put the patient on continuous monitoring. The term computerized CTG is where the machine gives you the interpretation. It tells you what is the basal heart rate, what is the short-term variability, what is long-term variability, how many accelerations were present, how many decelerations were present. But again, the machine interpretation can be sometimes alarming unnecessarily. So you have to know what you are looking at and you should know the interpretations. There are certain observations which you should know. The C-section rate and the instrumental delivery rate has increased after electronic fetal monitoring. But these are based on studies in 80s and 90s where the machine itself was new, interpretation was not very clear, and the randomized control trials were not much. Okay, so now the other observation that they have found is in the perinatal mortality rate, there isn't much of a difference, but the incidence of seizures are less, and the long-term neurological consequences are no different. The incidence of seizures are less by 50%. See, that itself is a great advantage for us. When you deliver a baby and the baby gets seizures, it's very, very difficult to answer the patients. So even if that is the result that we get, that is also good. And remember, legally, the tracings are to be preserved for 25 years. Again, with the newer machine, it is stored in the cloud. You don't have to actually do any hard paper storing. Okay. And the staff definitely have to be trained because you will not be sitting with the patient 24 hours. It's a staff. The patient has to be taught and the staff have to be trained. And definitely, it is not a substitute for clinical judgment. The interpretation should always be with the clinical judgment. Only when you believe too much on the machine and then jump to conclusions and then do a C-section, the C-section rate is going to increase. And remember, the mother should not be left unattended. You put the machine and then you can't disappear because the patient is on already monitoring. You don't have to worry. That is not the attitude. You have to monitor the patient because maternal vitals have to be monitored and the fetal monitoring also has to be interpreted by you. So the advantages of this electronic fetal monitoring, it's easy to monitor. When you hear with the Pinard fetoscope, only you hear. When the nurse says she is able to listen to the heart rate, you really cannot rely on it. And here you listen, the patient listens, and the staff listens. It's a problem. It is easier to demonstrate to the patient. See, the heart rate was like this, suddenly it is going down like this during contractions. It's easier to explain to the patient. And for legal purposes, see, if you say I monitored the fetus, and if you don't have any records, then it doesn't stay in the court of law. So when there is for legal purposes, definitely you need this electronic fetal monitoring, and we can be at peace when the patient is being monitored. And with the newer machine, you can monitor from when you're sitting in the OP or even at home with the newer wireless models. That is a great, great boon. Most of us, almost 99% of us, we do only external fetal monitoring. And this is the routine thing that we do. The disadvantages with the external fetal monitoring is it's prone for signal loss when the uterus is over distended or when the patient is very, very obese. Even if you place the fetal Doppler, sometimes it may not be able to pick up the signal or the flow may slip. Okay. And as I said, sometimes it may be the maternal heart rate which is picked up. Whereas in an internal monitoring, this doesn't happen. And this double counting and half counting can occur during the second stage. I'll tell you what it is in the later stage. And an external fetal monitor may not record the cardiac arrhythmias of the baby accurately. Whereas internal monitoring is more advantageous, but it cannot be used as a routine, mainly because it is an expensive disposable electrode. In a country like India may not be possible, and the presenting part has to be clearly identified. When you close the probe internal monitor, the sutures and fontanelles has to be avoided and requires rupture of membranes, which means you are committing to delivery, and risk of vertical transmission of infections are there. So internal monitoring, most of us don't do. In a very selected centers, they do. This part we will skip. Okay. Coming to the actual interpretation of CTG. 5 features you have to note down. Okay. So there is what is called as Dr. C. Bravado. Okay. This we will see at the end. What does it mean? So before that, let us see what are the features that you are going to look for. First is the baseline heart rate. What is the baseline heart rate? You see, this is a with a wireless new machine, it gives you everything. So that says fetal heart rate is somewhere around 135. Okay. Then the variability. Variability is the smaller oscillations. Again, in detail, we'll see in the later slides. And are there any accelerations or decelerations? So these 4 things about the fetal heart rate. And when regarding the maternal part of it, how many contractions, how much is the duration and the strength of the contractions. Remember, in CTG machine, the frequency measurement is accurate. The strength and the duration is not so accurate. And again, in the newer machine, there is this barcode where the patient can download the barcode app, and then they can listen to the actual recording at home. That is again, patients are thrilled with that. So let's go to the first feature, that is the baseline rate of the fetal heart rate. This is the mean level of the most horizontal part of the tracing. At least for 2 minutes, it has to be observed. And which should be less oscillatory. Supposing this is an oscillation, right? This is less oscillatory. So the most horizontal part, at least for 2 minutes, you have to see the basal heart rate. It should be determined over a period of 10 minutes graph. When you do intermittent monitoring, you will listen to for 1 minute at least. When you do a monitoring or a tracing, continuous monitoring, you have to at least over a period of 10 minutes, you have to assess. It's expressed as beats per minute, and the baseline may vary every 10 minutes. Okay, so first half of the paper may have 135, the next half may have 145 or even on the lesser side. So the normal rate is between 110 to 160. Whenever there is, see, take this graph, the lower one. Where will you put this baseline heart rate as? Do you have this as basal rate and this as deceleration, or this as basal heart rate and this as acceleration? So this is a very difficult. This sort of graph happens when there is a state of active wakefulness for the baby. So in these cases, you either look at the previous recording. It is the same patient. If you see, it's the same patient. Okay. This is at 10:04 and this is at 5:33. So you see the previous tracings, it is normal. So this sort of tracings, whenever there is, when you're not happy, you're not able to assess, always look at the previous recording if it is present, or repeat the CTG after some time. And in term fetuses and post-term fetuses, the heart rate may be around 110, or even in post-dated, it can be a little lower than that. But if there is a good variability, you don't have to worry. In a preterm fetus, both these patients, this patient is around 39 weeks. Okay. This patient is around 34 weeks. So there is actually tachycardia, but even the basal heart rate will be on a little on the higher side for the preterm fetuses. That we should keep in mind when we interpret. Tachycardia, when the baseline value goes above 160 beats per minute, lasting for more than 10 minutes, you call it tachycardia. If it is for a short duration, you call it acceleration, right? So if it lasts for more than 10 minutes, you call it as tachycardia. The frequent cause for fetal tachycardia is maternal tachycardia, which is again due to an infection. Either if the mother has fever due to a cough, cold, or diarrhea, or if she has an intrauterine infection like chorioamnionitis, it can produce tachycardia. Tachycardia is less significant than bradycardia. If the heart rate is around 165 or 170, I may not worry much. But if the heart rate is around 100, I will worry much. Okay. And the FIGO doesn't consider this tachycardia as pathological. It makes it only as suspicious tracing when there is a fetal tachycardia. Apart from maternal tachycardia with the corresponding fetal tachycardia, what are the other things that can produce fetal tachycardia? If you give an epidural, there can be a slight rise in maternal temperature resulting in fetal tachycardia. And initial stages of hypoxia, there can be an evolving hypoxia, you can have tachycardia. And all the drugs given to prevent preterm labor. I told you preterm babies themselves will have a little on the higher side heart rate. But if she is in preterm labor and if you give tocolytics like salbutamol, terbutaline, ritodrine, etc., it can produce fetal tachycardia. Parasympathetic blockers, pre-medications like atropine can produce, and scopolamine can produce tachycardia. When you have ruled out all the conditions and still there is a tachycardia, always suspect whether there is any fetal arrhythmia, especially repeatedly if there is tachycardia, but there is a good variability. Otherwise, baby is good. You have to think of supraventricular tachycardia. In these cases, we have to inform the pediatrician that, and we should have the pediatrician around during delivery so that they can take care of the tachycardia. Yeah. So this is tachycardia. It is lasting for more than 10 minutes. This is 1 minute. This is 10 minutes. 10 up to 12 minutes, this fetal, not even 12, up to 14 minutes, this tachycardia is going on. Okay, see this green strip shows the normal range. Above that, you can just, by looking at it, you can see that it is in the higher range. Coming to bradycardia, a baseline heart rate below 110 lasting for more than 10 minutes. Again, if it is less than 10 minutes, you call it deceleration. If it lasts for more than 10 minutes, you call it bradycardia. So value between 100 and 110 can occur in postdated pregnancies. And whenever there is a bradycardia, always feel the maternal pulse and make sure it is not the maternal pulse you are recording. See, I had one patient who had confirmed intrauterine fetal demise with an ultrasound. Someone had referred. The patient had come. The sisters, till I come see the patient, they put them on CTG. So when they put the CTG, they were recording. And they were happy that it is being recorded, and it was somewhere around 90. But it was a intrauterine fetal demise. What was recorded was a maternal pulse. Again, it is very difficult to convince a patient in such situations. Okay, so you have to show them the ultrasound, see that it is not a fetal heart that is being picked up. And medicines that you give for hypertension, like labetalol, atenolol, can produce bradycardia, fetal arrhythmias. Like you have ruled out all the problems, and still the heart rate is in the lower limit. It is repeatedly like that. Then you have to think of fetal arrhythmias. Bradycardia is more significant than tachycardia. Less than 100 is pathological. Whenever we say pathological, it does not mean we have to jump and do a C-section. Whenever there is a pathological tracing, you reassess the patient, see whether there is any correctable cause, like a supine hypotension or a tachysystole due to a fast syntocinon drip. So look for all the features which can be correctable. If it is possible to correct it, correct it. And if it is recurrent, and if you think that the fetus is hypoxic, then only you have to go for a C-section. See this tracing. So from here to here, for almost 12 minutes, there was bradycardia. Then it has picked up and then it is normal. There is good variability and there are accelerations also. So this baby is not a hypoxic baby, and this is 39 weeks, 4 days. So that may be the reason for the bradycardia. This is one condition, acute bradycardia, where you have to do a emergency delivery. Okay. So acute bradycardia, heartbeat had been normal, suddenly it dips down and remains the same. Whenever it dips down like this and remains at the same level, make sure it is not intrauterine fetal demise, and that you are not tracing the maternal pulse. Okay, when can this happen? This acute bradycardia, it can happen in a cord prolapse. So whenever there is a polyhydramnias, when you do an ARM, suddenly the heartbeat drops, or there is a spontaneous rupture, the heartbeat drops, think of cord prolapse. And a PIH patient or any other patient, abruption can occur for anybody. Fetal heartbeat, it had been good. Suddenly the patient complains of severe pain, sweats a lot. Then there is the uterus is tense and you don't find the heartbeat, or when it is very low, think of abruption. And if you are giving a VBAC trial and suddenly heartbeat drops down, sometimes there can be silent ruptures without much of pain. So think of rupture uterus, and then in these situations, you have to do the delivery within 10-15 minutes. Those three situations, you will not wait for second opinion. You have to straight away go for a C-section. Okay. So first we have seen about the basal heart rate, increase, decrease, the normal variance, all that we have seen. Now we'll come to variability. Variability is a very, very important feature. Even if the the heart rate is around 165, the variability is good. Or if there is a heart rate is around 110 and there is a good variability, you can be at peace that the fetus is good, not hypoxic. What is this variability? It is the minor fluctuations in the baseline heart rate. See, this is the bandwidth. Okay, this bandwidth is in a 1 minute trace, you take the highest rate and the lowest rate. So this somewhere around 10 beats per minute. So this is variability. The bandwidth of the baseline heart rate, or in a 1 minute tracing, the highest rate and the lowest rate, the difference between them is called the variability. There is actually what is called the short-term variability and long-term variability, that we will not go in detail. Actually, short-term variability is beat to beat variability. Short-term variability is over a segment. We will, long-term variability. We generally look at the long-term variability. Okay, so this is long-term variability. This variability is good. One second. This we have seen. The variability, you look at this, this is absent variability. It looks like almost a straight line with the slight fluctuations which are very vague. And this is reduced variability. It is less than 5 beats per minute. This is normal variability. Between 6 to 25 will be the normal variability. If it is more than 25, you call it as increased variability. If it is really up and down, we call it actually saltatory pattern, more than 25. This reduced variability can occur in a fetus which is sleeping. So up to 50 minutes, if the variability is reduced, you can wait and watch. But you have to repeat the CTG. In spite of that, if it reduces, you have to see what is wrong. See, this is at actually 2 centimeter per minute tracing. You see this, the variability, the entire graph seems to be a straight line, but you still can see some variability. Okay, it is reduced variability. So she was asked to repeat the CTG. The subsequent CTG was good. Even here you can see that there is a variability here up to 10 beats. So this is not an abnormal CTG. This is actually a suspicious CTG which needs to be repeated. So if it lasts than more than 50 minutes, it is pathological. You reassess the patient. So this, you see, this is normal variability. This is a fetus 39 weeks. So the heart rate is in the lower limit of normal, but this is a good variability. Good variability is around, say 10 to 15 beats. You can enlarge and see. This is an increased variability. Okay, this is normal variability. This is increased variability. Increased variability, we really do not know what is the pathophysiology. It is presumed to be due to autonomic instability. If it lasts more than 30 minutes, it is pathological. Again and again, whenever we use the term pathological, it does not mean that we have to jump into conclusion and do a C-section. Only that acute bradycardia, you have to do an immediate C-section. All the other conditions, when we say pathological, reassess the patient. If there is a removable cause, remove it. And then if it continues, and then you can take a decision for C-section. Saltatory pattern, where it is really the difference between the bandwidth is so high, okay, more than 50 beats per minute. So this is a graphical representation. This is an actual tracing of a patient. Okay, so you see this, there are two tracings. This is what is called as double tracing. There is one in the upper side and there is one in the lower side. Actually, the machine can trace connectedly only if the difference between one beat to the other is less than 20. So in this case, between this beat and this beat, it is more than 20 difference. So there will be a gap in the tracing. See this tracing? There is no tracing here. Instead, it is there. It's a saltatory pattern. Like it is going up and down like this. Okay. So the variability is almost more than 50 to 60 per minute. Okay. This patient delivered normally. This was during second stage of labor, especially during Valsalva maneuver when she was straining. You see these contractions. These contractions are so frequent. Almost every minute there is a contraction and the contractions are strong. The upper limit you cannot see. See, this again is a saltatory pattern. See here, and then coming down here. Okay, this is not a artificial tracing. This is a normal tracing where it is missing here, you can see on the upper stage. It is up and down like this.
Ma'am, do you want to take a break now?
Yes, now we'll take a break. Shall I put stop share?
Yes, ma'am. So I can start sharing. Thank you, ma'am, for all the insights that you shared so far. So while ma'am takes a break, I'll take the opportunity to introduce to you all the wireless NST CTG device that ma'am was talking about, and she has shown you quite a few slides of the particular graph of that machine. So I'll show you how that device looks like and what are its features. I'll just share my screen. Are you all able to see my screen?
Yes, ma'am.
I'll start the presentation. So before I start, um, I'm Munmun Ganguly. I am the Business Development Manager with Care Mother in Mumbai. And Care Mother is an IT Bombay incubated company which deals in pregnancy care solutions and devices. So this is what Fetosense, our wireless NST CTG machine looks like. It is completely portable, as you see. These are its components. First of all, there is a tab which will act as the display screen for your graph. There is the NST or the FHR probe. Then we have the cardiotocography probe. Then we have a manual movement marker, which we give to the mother to trace the baby's movements. And then there is a speaker to amplify the baby's heartbeat sound. Couple of features that makes it different from the conventional CTG machine. As you see, it is completely portable. The dimensions of the kit will be something around 1 feet by 10 inches and it weighs around 1 kg. So it is absolutely weightless in nature. You can move it around in the OPD, IPD labor room without any efforts. It doesn't require a cart. To add to that, it being wireless, there is no wire breakage maintenance that is required for this device and there is no downtime per se for that wire breakage. Yeah, that's one of the features. It gives you real-time alerts for any form of abnormalities like ma'am was mentioning about. The second feature that comes with this device is something called remote monitoring. You as a doctor will have an app on your device with which you can monitor the test in real time from anytime, anywhere. So even if you're not there where the test is being done, if it's in labor room where the test is being done and you are in OPD or you're at your place or you're traveling somewhere, you will be able to see the test real time on your phone. The third thing that comes in this device is digital records. So this device is capable of keeping unlimited digital records for 20, 30, 40 years as well. So it's cloud storage, it's unlimited. You can refer back to any of the tests at any point in time at a later stage after doing the test. So it helps you with medical legal as well. And it helps you, since it is stored, you can share the data as well with any of your peers. You can share the data with the patients or anyone who is concerned. The next thing is this device prints on a normal A4 paper. It doesn't require a thermal CTG roll. So basically the printing cost comes down. Also, an A4 print is more durable compared to a thermal paper, which evaporates after a point in time. And to add to that, as ma'am showed you, there'll be a QR code which will be there in the print of the test, which the mother can use to download a mother's app, wherein she'll be able to hear the baby's heartbeat sound after the test is done. These are few of the rewards and the recognitions that our company has received. These are both our founders. This is Mr. Shantanu Pathak demonstrating our device to the Prime Minister. And this is Mr. Aditya Kulkarni. He is giving a prototype of the device to the Queen. If any of you all are interested in having a demo or a trial of the device at your respective locations, these are the contact details. For Tamil Nadu, you can get in touch with Mr. Mahesh from Zeal Medi Solutions. Zeal Medi Solutions is our official channel partner in Tamil Nadu. So you all can get in touch with them for a live trial or a demo. And for the rest of the locations, you all can get in touch with me directly. I'm Munmun Ganguly, Business Development Manager. And you all can arrange for a live trial or demo at your respective locations. Thank you for your patient hearing. Over to you, ma'am.
Yeah. Yes. So the first two features we saw, basal heart rate and the variability. Now we'll go to acceleration. What is acceleration? a transient increase in the fetal heart rate of 15 beats per minute above the baseline and lasting for 15 seconds. You take this part. Okay. This heart rate is going from basal heart rate is 150. From 150, it is going up to 165 and it is lasting for about 4 minutes. Okay. So this is an acceleration. This will be the basal heart rate and this is an acceleration. Okay, it should be less than 10 minutes. If it is lasting for 10 minutes, if this is going to be like this continuously, then it becomes a change in the basal heart rate and not an acceleration. So a typical acceleration you can see here, a triangle shape goes up and then comes back to normal. In preterm fetuses, the amplitude, that is the height of the accelerations may be less. It can be of shorter duration also. Most of the times the accelerations coincide with the fetal heart rate. You see this? This is the heart rate I told you, I mean fetal movements sign I told you. So this, whenever there is a movement, there is an acceleration. There is a movement, there is acceleration. Okay, and this a little lesser, I mean not darker one, lighter marks are spontaneous movements recorded by the machine. It is a sign of neurologically responsive fetus, which means that there is no hypoxia. Accelerations may not occur during the period of sleep. So during the sleep time of the baby, which is usually taken as 50 minutes, the variability may be less, the heart rate may be a little on the lower side, and there may not be any acceleration. So in those situations, you repeat the CTG. In an antepartum CTG, accelerations should be present. In an intrapartum CTG, when the patient is in labor, if there are no accelerations, you don't have to worry. You just take the other two normal features like baseline heart rate and variability. If they are good and there are no decelerations, then it is normal CTG. Whereas in an antenatal CTG, you should be able to see the acceleration. Even if the baby has a variability between say 5 to 10, but has a good acceleration, you can be happy that the baby is normal and healthy. So coming to the next feature, deceleration. When compared to acceleration and deceleration, deceleration is more important. If it is present, it becomes either suspicious or pathological. Whereas an acceleration, if present during labor, it is good. If not present, you don't have to worry. So decelerations, what is deceleration? A reduction in the fetal heart rate of less than, heart rate should be less by 15 beats per minute below the baseline, lasting for about 15 seconds. The late decelerations can be again of a lesser height. It can be less than 15 beats difference. The decelerations are classified into early, variable, and late. Okay, this is a very nice representation of the decelerations. The decelerations generally have a V or a U shape. They have an onset and recovery. It is almost symmetrical, and in an early deceleration, the nadir of the deceleration corresponds with the peak of the contraction. It is like a mirror image. In a late deceleration, the shape and all is the same, but it happens after the contraction. The nadir of the deceleration is after the peak of the contraction. Okay, so the early deceleration and late deceleration, if you don't look at the contractions, you cannot interpret. That is why you should always have a tocoprobe and you should always look at the contractions and interpret. So this is early deceleration, this is late deceleration, where there is an onset and a recovery has a V or a U shape and you correlate with the contraction. If there is a deceleration, doesn't fit into early or late, you put it as variable deceleration. A variable deceleration can occur before the contraction, during the contraction, or after the contraction. The shape will be different. Let us take the early deceleration. It is an uniform mirror image of the contractions. You see this? You can see that the nadir of the deceleration corresponds with the peak of the contraction, and this is usually due to head compression. It is benign and you really don't have to worry. You can relax, it is nothing to worry. See, in this again, see, looking at this, you feel really worried, no? It looks very abnormal. But if you see, the nadir of the deceleration corresponds to the peak of the contraction. This is an early deceleration. So you should always correlate with the contractions to interpret the deceleration. Late deceleration, as I said, again, they are uniform, repetitive. They have a slow onset. That is, after the contraction, it starts, and then the nadir of the deceleration is after the peak of the contraction. So if you draw a line, this is a deceleration, this is a nadir. If you draw a line, you see that it is after the peak of the contraction. So in this patient, she had late deceleration. She was on syntocinon. So syntocinon was stopped and then it returned back to normal. She delivered normally also. So this late deceleration is generally caused by uterine hypoxia. The commonest cause for uterine hypoxia is tachysystole. Like when you give a little increased dosage of syntocinon, the uterus may contract continuously and then it can produce hypoxia. So coming to variable deceleration, as I said, if the deceleration doesn't fit into early or late, then you put it as variable deceleration. Majority of the decelerations that you observe during labor are variable deceleration. The time correlation with the contraction is variable, and should we worry about variable deceleration? Why does it occur? The variable deceleration is usually due to a cord compression. When the umbilical cord is compressed, the arterial pressure of the baby increases. When the arterial pressure increases, the baroreceptors are stimulated, and that produces deceleration or decrease in the fetal heart rate. See, the cord is a mobile organ. It can go this way or that way, so it can be variable. Sometimes some contractions it may be compressed, some contractions it may not be compressed. So it's going to be more common with oligohydramnios. Okay, they are generally not associated with a bad result. The fetal hypoxia is not so very common, but there are certain concerning features with the variable deceleration which you have to look for. If they are present, they are pathological, then you have to reanalyze. So what are the things that you should look for in a variable contraction, variable deceleration? A variable deceleration, first and foremost, you will diagnose variable deceleration only if they are variable in relation to the contractions. So beginning and end. Then see if there is what is called as shouldering. What is shouldering? Just before the dip, if there is an increase in the heart rate, a slight increase, that is called as shouldering. This is shouldering. This area is called shouldering. If shouldering is present, it is good. You don't have to worry. It is a non-concerning feature. Then the duration of the deceleration. How long is the duration? Okay. If the duration is more than 5 minutes, it is pathological. See this trace. This is an older graph. This is set at 3 centimeter per minute. Then in that case, 1, 2, 3, 4, 5 minutes. It is lasting more than 5 minutes. See this graph. Okay. Here there was a deceleration. It was almost for 3 minutes. Again, it went to the normal range. Again, it dipped. This again is for 3 minutes. Okay. So if you forget this, then it will become almost continuous 5 minutes deceleration. Okay. So if it is more than 5 minutes, it is again a concerning feature. This is generally due to cord compression or hypotension. You give epidural, suddenly there is a fall in BP, or if the woman had been in supine position for more than 5-10 minutes, if she has a hypotension, there can be. So it can also happen with uterine tachysystole. Tachysystole is when you give an induction of labor or acceleration of labor. Then if there are contractions which are too frequent, in this case patient, you see the contractions are very frequent. Okay. In those cases, this prolonged deceleration can occur. It can also occur when you do a pelvic examination, when you try to stretch the cervix and then do a little longer pelvic examination, or if you try to place a scalp electrode, or if the patient strains in the second stage, this sort of deceleration can occur. So prolonged deceleration is pathological, but again, you reassess the patient. If there is a removable cause, remove it. And if it is in the second stage, and if it is possible to help out the patient with an instrumental delivery, do that. The third point, first we said, is there any shouldering? The second, whether, one second. Second is the duration of the deceleration, shouldering and then duration. Here you see there is no shouldering, and then does it return to normal? See this, if you take this as a baseline heart rate, this dips down, this is not symmetrical. So the recovery is taking a longer time. This is like a tick mark. It's not V or U shaped. Okay. So the recovery time is more. The recovery to normal rate is somewhere here. Once it reaches a normal rate, again it dips down. Okay. So this sort of longer time to recover is again a concerning feature. This particular patient actually was a second gravida. First baby was a normal delivery with us only. The second baby, she was only 30 weeks pregnant at that, 30 weeks, 5 days. And she went to another hospital with history of loss of fetal movements. The tracings was like this. Actually, I had before, the entire half an hour tracing was like this. They had repeated twice, it was still the same. And we repeated, it was still the same. So almost 4 half an hour tracing, she had the same. So then I didn't know that time. I had consulted another friend who had done a fetal medicine. She said, this looks like a terminal CTG. Okay, because the entire tracing was like this and with no contractions. This was an antenatal patient, 30 weeks, 5 days, who had only reduced fetal movements. She had a little IUGR features and we had to deliver by LSCS. Baby was hypoxic and had to be in NICU for almost 2 months. So beginning of the deceleration, I told you, shouldering, then duration, then recovery. How long does it take? You see this? This is a symmetrical. It comes and then goes back. Okay. And does the deceleration last for a longer time of the trace? You do a half an hour tracing. Almost all the half an hour, all through the contractions, if it is present, then it is significant. If the decelerations last for more than 30 minutes, they are going to be significant. Repetitive. Does it come with every contraction? When we say repetitive, does it come with every contraction or after every contraction? When we say that duration of the duration of a particular deceleration, this is duration of a single deceleration. The time, the trace, the entire trace, if it is abnormal. See this again, it is repetitive. For the entire trace, it is deceleration. It is occurring with more than 50% of the contractions. It is again significant. the shape of the deceleration. You take this patient, it is W shaped. See, if the deceleration came, touched a baseline, again it went down. Okay, so this called biphasic or W-shaped deceleration. That is abnormal. And when there is a deceleration, in this deceleration also, there should be variability. It should be serrated or something like a sawtooth. If this is smooth, if the deceleration curve is smooth, again it is a concerning feature. So shouldering, duration, recovery, is it repetitive? Is it there throughout the trace? What is the shape? Is it biphasic? And is there variability within this deceleration? With this, you will classify this variable deceleration as a one with a concerning feature or without concerning feature. This pattern, sinusoidal pattern, this doesn't fit into our regular interpretation. It doesn't have a baseline heart rate. It doesn't have variability. It doesn't have acceleration. It doesn't have deceleration. There is a regular smooth oscillation. See, 50 up to 15 beats per minute. For a minute, there can be 3 to 5 oscillations. This sort of regular oscillations is called as sinusoidal pattern. A regular smooth, it is not sawtooth. You see, this is smooth. A regular smooth oscillations resembling a sine wave up to 5 to 15 beats per minute, up to 3 cycles per minute. Okay, this is sinusoidal pattern and there are no accelerations. See this? This is a regular smooth oscillation throughout the graph. These are contractions. Okay. This happens, this sinusoidal pattern happens in fetal anemia. The commonest cause that we can come across fetal anemia is Rh isoimmunization. But it can happen in a fetal maternal hemorrhage whenever there is a placental abruption or a placenta previa bleeding heavily, or if there is a twin-to-twin transfusion, the anemic fetus will show a graph like this. If there is vasa previa and if the membranes get ruptured, there is a hemorrhage from the blood vessel that can produce sinusoidal pattern. It can also happen in acute fetal hypoxia, cardiac malformations, hydrocephalus and gastroschisis. Most of this infection, of course, again, we may not be able to detect. Cardiac malformations, hydrocephalus, gastroschisis, and all, most of the time we would have diagnosed by ultrasound, so we don't have to worry. So this basically means sinusoidal pattern. There is fetal anemia and hypoxia. This is again a terminal CTG. If this sinusoidal pattern lasts for more than 30 minutes, we have to deliver the baby by C-section. A pseudo-sinusoidal pattern. Sometimes you'll be wondering, what is this? It looks like a sinusoidal pattern. How do you differentiate sinusoidal and pseudo-sinusoidal? Pseudo-sinusoidal will not have a smooth curve. It will be again a jagged sawtooth appearance, will not last more than 30 minutes. It will be characterized by normal tracings before and after. That is why whenever there is something suspicious, you always repeat the CTG. How much later you can repeat? Maybe half an hour later or 1 hour later, depending upon the situation. This pseudo-sinusoidal pattern can occur after an analgesic administration. Okay, so when the mother also tends to sleep and the baby also maybe sleep, it can also occur when the baby sucks and with other oral movements of the baby. So see this appears to be a straight line. There is variability. So you are wondering whether this is sinusoidal pattern, but you see this is not a smooth curve. This is sawtooth appearance is there. So this you can put it as pseudo-sinusoidal pattern. So this patient, we have to repeat the CTG after some time. So baseline variability is present, accelerations are present. It is not associated with adverse outcome. So when do you do an antepartum CTG? Antepartum CTG you will do only after the period of viability. We can say after 28 weeks. Before that, if you do a CTG, it is of no use. Before that, if the patient says loss of fetal movements, you do an ultrasound and Doppler study and not a CTG. Whereas after 28 weeks, because only after 28 weeks in our place, we will be able to salvage. Of course, there are centers where they can stay from 22 weeks onwards, but it is better we start from after 28 weeks when needed. There are no clear guidelines for antepartum CTG, whether you should do a CTG for an antepartum patients. But generally, for any woman who comes with reduced fetal movements, if you don't have an access to the ultrasound, the first thing that we will do is to put her on a electronic fetal monitoring. And all these high-risk pregnancies where there is growth restriction, where the mother is a diabetic or a hypertensive, she is on serial growth scan with Doppler. And in between when she comes, if her growth scan with Doppler is due only 2 weeks later, but you will still feel a little happy if you do a CTG in the every week and then see. Okay, in those pregnancies. And in post-dated pregnancies, as a policy for us, post-dated pregnancies, we ask them to come every alternate day after 40 weeks plus, and then we do a CTG at every visit. If the CTG is normal, at least for the next 24 hours, there may not be any big problem. Okay. And sometimes when the patient keeps on coming for repeated false pain, okay, repeated pain, and you don't find any contractions, and you're not able to appreciate any contractions, you need a document to say that there are no contractions and the baby is good. In those situations, again, every time she comes, you may have to put her on a CTG and then see if there are contractions and how the response of the heartbeat is. Okay. So antepartum CTG, this is what we have already. You will report it as either reactive or non-reactive. Okay, antepartum, you just use these two terms. Accelerations should be present in antepartum CTG. Any other abnormal feature, if they are present, like a deceleration or a bradycardia or a tachycardia, in a person who has no contractions, that is antepartum CTG, you look carefully again because it is unprovoked event. So whenever there is an unprovoked event, evaluate properly. And then with an antepartum CTG, what are the things that you will decide? Mainly whether she has to be admitted, observed, or whether she can go home and come back later. To take that decision, this antepartum CTG will help us. Intrapartum CTG, this is the most important use of a CTG. So intrapartum CTG can be intermittent monitoring. Intermittent monitoring for all women in labor, whether low risk or high risk, we need to intermittently monitor, and continuous monitoring for all high risk pregnancies. And when you do an intermittent monitoring, you come across some abnormal features, then you go for a continuous monitoring. Okay. And when there is an acute event, as I said, you do an ARM, suddenly there is a problem, there is a dip in the heart rate. So till the patient is taken, getting theater is ready, you have to put her on continuous monitoring. Okay. Or when you give an epidural, you put a patient on continuous monitoring. Or if there is non-progression of labor, you are not happy with the progress, you have induced with gel, then you have given meso, then you have given Synto, still she is not responding, put that patient on CT, continuous monitoring. I would like all of you to remember this. This is very easy to remember. For interpretation, if you remember this, it will be easier to interpret. You remember this abbreviation, Dr. C. Brevedo. Okay. What is DR stands for? Defined risk. Okay. So what define the risk? Patient has IUGR, patient is a diabetic, patient is a hypertensive, she has PROM, she has fever. Okay, whatever the risk factor, you have to write. Then look at the contractions. Is she in labor? There are no contractions. She has regular contractions. Just look at the frequency and the duration of the contractions. Okay. So DRC finished. Now coming to bravado. BRA is for baseline rate, baseline heart rate. Okay, that is BRA. So the 3 letters stand for a single criteria, that is baseline heart rate. V for variability, A for accelerations, D for decelerations, and with all this you write an overall impression. That is, overall impression is your plan. The CTG is normal. Patient can be observed. You can continue with the induction. So whatever you are planning to, or you want a repeat CTG, you write you want a repeat CTG. Or if you want to have a decision for C-section, you write it. So with your CTG, you write this Dr. C bravado. Previously, I was trying to follow RCOG guidelines for interpretation of CTG, which was a little complicated and impossible for us to remember in a very acute situation. So then this FIGO interpretation and recommendations in labor came in handy, and this is very, very useful. Now you take all the 4 features of the fetal particle: baseline, variability, deceleration, and see, you accelerations doesn't come, because accelerations, if they are present in an intrapartum CTG, good. If they are not present, you don't have to worry. Okay, this is interpretation in labor. Okay, so only these 3. Then you interpret, decide on the clinical management. See, the features that you have to be worried or not worried: interpret, baseline, variability, and deceleration. Okay, normal, you all know. Okay, so when it is normal, you have this chart in your labor room, and then it's easy for you to tick where there is a problem. When is it becoming suspicious? Any one of this is abnormal, but doesn't have this pathological feature, it becomes suspicious. Say the heart rate is around 170, but no other problem, then it becomes suspicious. Okay, there is variability, reduced variability around 5, but it is not more than 50 minutes, then it becomes suspicious. Okay, there are no repetitive decelerations are there, but once in a while it is there, then it becomes suspicious. So any abnormality, any one abnormality in this, but it doesn't come under this pathological category, you put it as suspicious CTG. So when you interpret that overall impression, when you write this overall impression, you have to write any one of this. You have to write either normal, suspicious, or pathological. Okay. So what will you do if it is a suspicious CTG? If it is a suspicious CTG, the probability of having hypoxia or acidosis are less. But if there is a correctable cause, if you can identify, correct it, then in these cases, you have to go for a continuous monitoring. And if there are any additional methods to assess hypoxia, like a scalp electrode or a fetal blood gas analysis, you have to go for it, which is not possible in our setup, routine setup. Okay, so if the CTG is suspicious, you ask for a repeat CTG or a continuous monitoring, and if it is a correctable cause, you correct it. Then coming to pathological. See, pathological, if the heart rate is less than 100, it is pathological. If the variability is reduced and it is there more than 50 minutes, I told you, generally the sleep cycle for the baby is around 50 minutes. In that 50 minutes, there can be reduced variability. There may not be any accelerations. Heart rate may be somewhere around 110. In those situations, usually after 15 minutes, it recovers. Okay, so if it is lasting for more than, repeat CTG also shows bradycardia and reduced variability, then it becomes a pathological CTG. Or an increased variability. It can occur in the state of wakefulness for the baby, but should not last for more than 30 minutes. If it is more than 30 minutes, again it becomes pathological. Or if there is a sinusoidal pattern more than 30 minutes. Okay, this becomes pathological. Coming to decelerations. If the decelerations are repetitive late deceleration, you see an occasional deceleration, you don't worry whether it is early, late, or variable. But there is a repetitive late deceleration or a prolonged deceleration for 5 minutes in a 30 minutes trace, then it is worrisome. The deceleration is associated with a less variability. I told you in a deceleration, even in the deceleration part of it, you have to look for the variability. Even that has to have a sawtooth appearance. In case that is smooth, you reduce the observation time to less than 20 minutes. Okay. Or if there is one prolonged deceleration for more than 5 minutes, it becomes pathological. There is high probability that the baby has hypoxia. And in these cases, immediate action to correct reversible causes. Okay, again, in these cases, he doesn't say you jump to C-section. You reassess the patient. Okay, if there is a correctable cause, what could be the correctable cause? It could be a hypotension, or it could be a change in the posture you may need. So any of those things, or if the patient has been on syntocinon, remove the syntocinon drip. Okay, so if there is a reversible cause, you revert it. If it is not possible, if there is no correctable cause, then if it continues, if the problem continues, you try to make arrangements for a early delivery. You be prepared for a C-section. And in acute situations, like the three things that I told you, cord prolapse, uterine rupture, and placental abruption, immediate delivery. In these three situations, cord prolapse, uterine rupture, placental abruption, there will be an acute bradycardia. So you have to immediately plan for delivery. In all the other conditions, pathological conditions also, you reassess the patient, correct if there is a correctable cause, and there is no correctable cause, observe for a little longer time, and if it is repetitive and with the clinical situation, if it warrants C-section, then go for a C-section. What are the terms that you use? Again, in RCOG, they use reassuring as normal, non-reassuring suspicious, pathological as abnormal. Thank you. Now you can ask questions. 1 second. Hello. ಇಲ್ಲ ಇನ್ನೂ ஒரு 5 minutes தான். 5 minutes.
Ma'am, there is one question in the chat box, ma'am.
Yeah.
If you can see that. About acute fetal bradycardia.
Yes, nuchal cord, if it is short and if there is contraction, if it is down, it can cause bradycardia. And it can cause bradycardia and deceleration as well.
If any of you has any other questions, you can please go ahead one by one asking those questions.
Okay, then we'll wind up, Munmun. There seems to be no questions.
Okay, ma'am. Before all of you go back, please switch on your cameras for a group photograph. Gajanan, can you please click that photograph? I request you all to please switch on your cameras.
Hi, Nalli.
Hey, ma'am. How are you, ma'am?
Fine, fine, Nalini.
Everything. Happy New Year, ma'am.
Thank you.
Mahesh, Balaji, can
May I
you
ask one question,
be on the
ma'am?
call?
Yeah, sure.
Ma'am, in case of epidural analgesia, what kind of CTG variations we are getting? Mostly we are getting a variable deceleration kind of thing throughout.
Yeah, variable distillation or bradycardia also can occur.
Okay, but in that case, we can give
Any abnormality, and see, sometimes it can produce a little rise in temperature and can produce tachycardia also. And some, because of the hypotension, it can produce bradycardia or variable distillation also. In these situations, correct the hypotension, change the posture, and then continue the CTG. You have to go for a continuous monitoring. The problem continues and you think there is no progress or any other added obstetric factor, you may have to go for a C-section.
Okay, ma'am. Thank you, ma'am.
Thank you.
Yes. Request all participants to please click on the camera. That can take a zoom in and keep it as a proof.
I think people may not, you just have to take the
Again,
number of people attended because already some 15 people have left.
yes, yes,
We'll
yes.
find out.
Okay, ma'am. I have taken few pictures also. Yeah. Thank you so much, ma'am. It was really insightful.
Very nice presentation, ma'am.
Thank you.
Thank you, ma'am. It was a very insightful presentation for all of us. We also got to learn a lot.
Thank you. Thank you.
Thank you. Thank you, everyone, for attending. Hope to see you all around for the next webinars. We'll be posting regularly about the next webinars that we'll be doing. So please keep an eye for that. Thank you. Thank you for
Thank
attending.
you. Thank you.
Thanks a
Thank
lot,
you.
doctor. Thank you very much.
Yeah, Mother and Zeal Medi Solutions. Thank you.
Thank you, ma'am.
Thank you, ma'am.
Yeah, say thank you. Mama want to give this. Thank you. Suti, mommy. Yeah.